Hi, I'm Dr. Howard Zucker, the doc in Docology. 60 years ago this month, President Lyndon Johnson signed into law the Medicare and Medicaid Act. That is probably one of the most transformational moments in the American healthcare history. And since then, these two programs, Medicare and Medicaid, have provided healthcare coverage to literally about 135 million Americans. And then we fast forward to today, and we find ourselves at another critical juncture. The budget bill passed by the Senate, still before the House, has significant changes in Medicaid, changes that the nonpartisan Congressional Budget Office is saying that there will be 12 million Americans losing their healthcare coverage. And there's plenty of passionate rhetoric going back and forth in Capitol Hill right now, echoing through the hallways. And there's a lot of uncertainty. But how does this really affect people? And there's no one better to help us sort through all of this than my guest today. And that is my friend and colleague, Tom Scully. Tom was the administrator for the Center for Medicare and Medicaid Services, CMS as we know it, under President George W. Bush. And he helped shape the Medicare and Medicaid programs and modernize things. And he also led to the creation of the Medicare Part D, which is the prescription drug benefit. He's a policy expert. He's known inside and out of Washington. Everyone calls him about everything. And he can help tell us about how this affects people, patients, all of us, and helps break it down. So, Tom, it is great to have you here today. I am thrilled to see you. And I think back about how it's been 25 years, almost 25 years now since we first met. I was naive. I was young. I was new to government. We both were working for Secretary Thompson. You were running the CMS. You were making policy. But I do remember the secretary always saying, "Where's Scully?" And what did he just say about that? So that always sticks in the back of my head. So I'm glad you're here today. Thank you. Thank you for joining us.
You were always nice and you're always fun. And it's Tommy Thompson, for those former governor of Wisconsin and then secretary of HHS. Because I did have a habit of saying what I thought. He'd say, "I fired Scully every Friday," and then I had to rehire him every Monday.
Right. So, and I was going to say that, but then I decided I shouldn't mention that. But that's exactly true.
We're still good friends. And he was a great boss, and I love him, and he's a good man. So it was a little bit, that was a rough and tough time legislatively, but things were much more civilized back then than they are today, unfortunately. So I think that's part of the problem.
I know, and we had so much going on then at that time as well, whether it's Medicare and Medicaid, but just in general, because that was right after September 11th and anthrax and all these other issues that were happening. I thought maybe you could help us starting at like the 60,000 foot level. What's the overall view of what will happen to Medicaid if the House passes this, goes to the president, he signs it? I mean, is this a tweak of the current law, or is this sort of transformational change? Like, what's really happening here?
Not much. So as usual, unfortunately, the rhetoric is way overblown and inaccurate on both sides, sadly. So in my opinion, just to take it back a step and look at the big global, what's driving all this activity this year is that Trump wanted to extend the tax cuts he did in 2017. And under budget law, you're supposed to pay for it. So to extend all the existing tax cuts that he did back then in his first term, was going to cost about $3.5 trillion. And the traditional way you do that is, you either raise taxes, which they didn't want to do. You cut Medicare, Medicaid, Social Security, defense, and everything else. But all the main money is in Medicare, Medicaid, and defense. And normally it's not cuts, it's reductions in the rate of growth. So instead of having the program grow at 12% a year, you do tweaks to have it grow at 5 or 6% a year. And that's been going on for years. There basically was a complete lack of profiles and courage on all sides. So the Republicans, in my opinion, and they disgraceful, since I'm a Bush Republican, I'd say I'm a mushy moderate, but fiscally conservative Republican. Instead of bucking up and saying, "Look, we want the tax cuts, to continue. They're big tax cuts." But, taxes would have gone up dramatically on just about every American if they expired. So you could argue that it would have been a bad shock to the economy to have those 2017 tax policies expire. But you could have a mix. You could let them go up a little bit. But instead, they just changed the budget rules and said, we're going to ignore the fact that we have to pay for it. And we're just going to say this is current policy, so it's free, which is really, from a budget person's point of view, and I spent many years running Medicare and Medicaid, but I also spent many years at the Office of Management Budget under the first President Bush, it's just outrageous. And what it did is it took the pressure off, because if you don't have to pay for it, then you don't have to do any cuts. So if you look at, you have, I used to run the second biggest hospital association in between Bush administration. So believe me, I'm very capable, and I did for years, screaming bloody murder anytime mentioned anybody touches Medicare, Medicaid. Hospitals are going to close. We're going to cut hospitals. You're going to kill people. Babies aren't going to be born. That's what you do if you're a hospital association. I get that. That was my job for 6 years in the 90s, and I did it just like anybody else. But it's not. I mean, the reality is nothing is going to happen in Medicare for the next till Trump is gone. So basically, if you're running a hospital, you have a policy-free zone for the next 5 years. There's a lot of stuff in Medicare that could be fixed to save money. So they give that a complete olay just because Trump didn't want to touch it for political reasons, which I understand. But, it needs to be done occasionally, and they didn't do anything. On the Medicaid side, I would say as a Medicaid person, they did 5% of what I would have done on a pure policy basis. Is it going to be painful in some places? Yes. But the main thing they did, not that I always agree with, they did work requirements for work age eligible single people, which, I'm not a big fan of work requirements. It's been tried in some states. It may or may not work. On paper, it saves a lot of money. It's going to cause some chaos, but, I'm not sure it's going to be, and it gets done state by state. I don't think the work requirements are terrible. They also said the people who are legal aliens cannot get Medicaid. There were some massive expansions that President Biden did, whether you like it or not, just, fact of life. In the Biden administration during COVID, they did massive expansions of Medicaid, and they did pretty massive expansions of the insurance exchange subsidies. Those both insurance exchange subsidies naturally go away. So people are going to be coming off the insurance exchange just because the supercharged subsidies that President Biden did in those 4 years were temporary. They go away too. So there's a little complaining about that. But essentially, by doing income verifications, making sure you're qualified for Medicaid, because during most of the COVID years, they suspended any income verification. So if you had to be under, just pick a state, if you had to be under 200% of poverty in New York, I think it's actually 300 to get Medicaid, and you got a job. If you were on Medicaid in 2021, they didn't check again. They just started recently. So they're starting to say, look, if you're going to get Medicaid, you have to be low income to get Medicaid. So that's taking some people off the rolls. The biggest thing the hospital is screaming about is the thing that's totally outrageous that I've been fighting for 40 years, which is the states, the Medicaid program is supposed to be a state, as you well know, because you ran it in New York. Oh, yeah. It's a state Medicaid, state federal match. So in theory, the state of New York is supposed to spend, if they put up, $100 million, the federal government matches that with $50 million. That's $50 million state, $50 million federal. Well, it never works that way in any state. The states cheat by doing these provider taxes, intergovernmental transfers. They'll just to simplify it, they'll go to a hospital and say, we used to pay you $100 for a service. We're going to pay you $200 a service, and then we're going to have you transfer it back through provider taxes. A million ways to do it. So that effectively the state is not putting up any real money. So state by state, the match rates have gone crazy. And this is not New York's fault. It's happened for 40 years. I'll give you the worst example. I was on the board for 12 years at the Dartmouth Med School. I have a lot of family at Dartmouth. My daughter went to Dartmouth. I got on the board of the Dartmouth Med School for a variety of reasons. The state of New Hampshire hasn't put a penny into its Medicaid program in 30 years. It's 100% federally financed. That's not good. So, and when you look at, is it fair that Mississippi, which is the poorest state that hasn't figured all this out, actually pays its 20% match rate and gets 80 from the federal government, while New Hampshire, which has no income tax, pays nothing? They basically put zero into their, and I can tell you this has been going on when Governor Sununu was my boss in the White House and for President Bush in 1989. He came in, I'll just finish with this story. Governor Sununu came in and I said, Governor, I've discovered the states are just using these scams to basically goose their Medicaid match rates and not put up any money. And he said, Scully, I'm the governor of Hampshire. You don't think I know that? I love it. I've been doing it for years. But now that I'm the White House chief of staff, I'm with you. I want you to go shut it down. That's the way it works. Every state and every governor wants to keep this money so they don't put money up. But it's terrible federal policy. And I can tell you there's not a single human being in the United States at CMS or anybody else that can tell you what the real match rate is for all 50 states and 6 territories. It doesn't exist because for 40 years, there haven't been any rules. So if Congress and the administration wanted to consciously go out and say, let's have every state get a 95% match rate, and they want to put the money up, great, but that has not happened with any set of rules. So you've got scrambled eggs. And every state's get a different deal. It's $1 trillion a year of horrible federal policy.
It sounds that way. Yeah, it sounds like there's a lot of different components to this. Can I just unpack a couple things here? Because you brought up a couple points. One is the rural hospitals.
Yeah.
And I want to talk about that, and also a little bit about the work requirement. Because on the rural hospitals, when I was the commissioner in New York, a substantial part of the costs were, especially for inpatient care, as well as obstetrical care in those rural hospitals, came from Medicaid. And what I'm hearing in New York is a lot of people saying this is going to affect my relatives, and the rural hospitals rely heavily on Medicaid reimbursement. So I'm trying to get back to, like, how does it affect the actual person out there on that issue? And then, so let me start with the rural hospitals, and then we'll talk about the other.
That doesn't affect them at all. What it affects, because there's nothing in the bill that says they're cutting rural hospitals. In fact, they create a $100 billion pot to help rural hospitals. What they're worried about, what the hospital's worried about, is provider taxes and intergovernmental transfers, and they're called state-directed payments. These are the ways that states found a way to basically draw down the federal Medicaid money without putting up any of their own. And New Hampshire's the best at it. There are a few other states that are just as good. New York is pretty good at it. New York's supposed to have a 50-50 federal match. I would, if I were betting you really went through New York, I would bet New York, and you'd be very hard to actually figure it out, probably puts up 10 to 12% of their actual state spending. The rest of it's federal. And they have a massive per capita spending, way bigger than any other state. They're basically, not as big as California. They spend virtually the same amount as California. So New York's been very artful at running all kinds of stuff through the Medicaid program. God bless them if, they're doing what they should be doing for the state of New York. But at some point, what they're doing in the Senate bill, which the Senate bill is what passes, is they basically froze the current provider taxes. They couldn't get any more because every state's been goosing these things. They're running more and more stuff through it and getting better and better federal feedback. They essentially capped these enhanced match rates that were done under Biden. And they basically said, going forward, we're going to cap the provider taxes, because the way they raise the state money is they tax the hospitals. They bring it into Albany or, whatever the state capital is. They send this to the federal government for their match rate, and then they give it back to the hospitals. So everybody wins but the federal government. Does that make sense? It's like a little Ponzi scheme. It's been going on for 40 years. It's outrageous. But everybody's been counting on for the next 10 years, this will keep going on, and every state can get more. Nevada just did a massive expansion on this, completely bogus. It was grandfathered into this bill. But people like to do more of it over the years. And what they basically said is we're going to freeze provider taxes and intergovernmental transfers and all these ways you guys goose your matches. We're going to freeze them where they are. And then starting in 5 years, we're going to, depending how you read the Senate bill, we're going to put a cap on them from 6%. Right now, you can have a 6% tax on providers, which then goes back to the state, and the state uses its first match. That's how they collect all their money. And they're going to bring it gradually down to 3.5%. I think that's minimal. So if anybody's going to say, we're going to hurt rural hospitals, going to cut rural hospitals, it's 100% because of the provider tax provisions and the perception that someday the states might be squeezed a little because the states aren't going to be willing to pay the hospitals as much because they're free money. This is free money from the federal government done through this, financing scam.
Go ahead. Yeah, go ahead.
So nobody's cutting anything. They're limiting what should never have been going on for the last 40 years and trying to slowly get it back in the box at a pace that's about 1/5 of what I would do.
So if you were out in Cooperstown, New York, which is home of Baseball Hall of Fame, right? Rural area, hospital there, you need to have a baby, you're on Medicaid, you will continue to get that care. And if you were inpatient in one of the hospitals there, a major hospital there, that wouldn't be an issue. You're saying that'll continue to move forward. Right. Because I know not the hospital administrators, but hospital associations, they're strong, particularly in New York, and they're pushing.
Believe me, I've known Ken Rasky and those guys for 40 years. I get it. They used to come scream and yell at me, same thing. The sky is falling. And I used to do the same thing when I ran a hospital association. That's what you do. Right. So look, it's the best outcome for them is no change, and just to keep getting what they're getting. But I can tell you, in my opinion, in 2 or 3 years, the big impact is going to be, there may be some undocumented aliens in upstate New York that aren't getting services, and they are going to be uninsured, and they're not going to be covered by Medicaid. That's probably obviously a problem, but that's a policy decision. The states are going to have a little more difficulty starting 5 or 6 years out and finding a way to not put up real state revenue, but to put up, they're going to have a little tighter time trying to do all these financial manipulations to draw down money without putting up real money for the state. And I don't blame the states for being unhappy about it, but the fact is it never should have happened 40 years ago. It happened to my watch 40 years ago. and I fought it unsuccessful years. I can tell you stories about these provider taxes affecting presidential elections back 40 years ago. That's how this is not, it's very, very arcane stuff, but it's been going on for a long time.
Ken, just for those listening, Ken Rasky is the president of the Greater New York Hospital Association. As sort of a little bit of inside people that we work with. Back on the issue of the work requirement. So here's one of the things that sort of troubles me. You have somebody who ends up losing their job, and then they turn to Medicaid to get healthcare coverage, but then you say you need to have a work requirement, or not you, but they're saying you need to have a work requirement to get Medicaid, but it's sort of a catch because they lost their job. So how do we unpack that?
The work requirement is 10 hours a week of something. It could be volunteering at a charity. It has the theory. I'm not sure they agree with it or not because it's a pain in the neck to track. And the argument from the people that don't like it is that it's a paperwork nightmare. People are going to lose their coverage. They don't fill the paperwork. They don't know what they're doing. The reality is, if you're single, if you don't have a family, you don't have kids, and you're a single working age person, and you're on Medicaid, either you have to get a job 10 hours a week, or you have to provide something for a charity or do something for the community. So it's not necessarily a work requirement. It's you have to do something. And, it's fairly minimalist. Do I agree with it or not agree with it? I think the rhetoric around it is worse than the reality. A couple of states have tried it. It hasn't worked particularly well because of the bureaucracy. But, you've massively expanded the Medicaid rolls. When I left CMS, Medicaid covered about, I think it was 31 million people 20 years ago. And now we're up to 90 million people. No, we're up to 80 million now. It was 90. It went to 97 million during COVID. So, but, when you look about the argument about people getting cut off Medicaid, and I sent you these charts last night. The numbers, that's just a fact. These are from CBO. Currently this year, there's about 79, 80 million people in any particular month enrolled in Medicaid nationally. It spiked at 97 million during COVID, but it's come back down to about 80 million. If you look at 11 years, and this is we see in the news about 11 million people are going to lose their Medicaid coverage. Well, basically, under the bill it's going to pass today, I think. If you look out in 10 years, 2035, there'll be, under the bill, the estimate is 79.5 million people on Medicaid. It's about the same. So you're going to lose some illegal immigrants. You're going to lose some people that didn't get work requirements. You're going to have, they're going to be theoretically tighter on making sure they have income verification to make sure people are on the rolls. Whether you like that or not, that's all, I think, relatively modest stuff. Nobody's cutting any payments or core of the program. It's all what Trump is saying is fraud and abuse. Now, whether you call that fraud or abuse or not, it's theoretically running the program more tightly by income verification and by qualification of citizens. That number in 11 years is going to be exactly what it is today, 79.5. So you're going to have the same number of people in the program. The reason they say they're cutting 11 million people are going to lose coverage is because if you did nothing and the program ran exactly as it did today and you kept all the match rates up I talked about, all the silliness that's going on, you'd have about almost 91 million people on it. So that's 11 million people that in 2035 would otherwise be on the program if you didn't do this stuff. So you're
saying it won't expand, it won't grow. It won't grow. And
yes.
So what the Congressional Budget Office is saying, when I mentioned at the beginning that they say 12 million people will be lose their coverage, you're saying they're not going to lose the coverage. You're saying that there won't be more people enrolled going forward.
If you did nothing to the program in 2035, there would be 11 or 12 million more people on the rolls. So you could say those 11 or 12 million people are losing their coverage, but they're mythical people that don't exist yet. And those would be people that might be illegal aliens in some states, that might be people that didn't have their work requirements, that might be people that didn't have their income verification. There's a lot of people during COVID for 4 years, nobody asked you what your income was. So if you're on Medicaid, you got a job, you didn't go off the rolls. So that's the theory. And do I think it's terrible, horrible policy? It's not disaster. My point, when you're saying we're taking 11 million people off the rolls, we're cutting babies, we're cutting nurses, we're shutting down hospitals. It's just not happening. So I'll give you an example. The other chart I sent you last night. So if you look at the federal payment of Medicaid dollars this year, just the federal side, the state side, federal side $650 billion this year. The state side's probably, depending on how you, like I said, the money's all funny money, so it's hard to know. It's probably 400 billion, 300 to 400 billion coming from the states, but it's all recycled through a lot of mechanisms, so it's difficult to tell. But the federal dollars coming out of HHS There's $650 billion this year. If you did nothing and kept all the current law and all the current policy, CBO says that in 2034, spending would go from 656 billion to 986 billion. So we'll go up by 340 billion over the next 10 years. If you do what's in the Senate bill, spending goes from 650 billion to 860 billion. So is that a cut? It's going up by 200 billion instead of by 230 billion. Does that make sense? So the point is the spending in the program is not being cut. It's going up at a slower rate due to a bunch of tweaks that none of which affect specific hospitals. So none of the there's a little bit of a tapping on the brakes on provider taxes. There's almost nothing done to the core Medicaid programs. And so to say that hospitals are going to close, and look, rural hospitals have a problem anyway, and I've been dealing with that for 30 years. Rural hospitals, you got a lot of Hill-Burton hospitals in small towns that were built with 120 beds in the 60s, and now they have 10 beds that are filled, and they can't recruit doctors, and that's a problem. That's a structural problem that should be dealt with, in my opinion, by building smaller micro hospitals and referring people to big cities when they get sick, because you can't, these hospitals, they can't lose these cities can't lose their hospitals. It's terrible if they do. But there's no justification for having a 120-bed hospital in a town that's got, 15,000 people in it.
Back to the 12 million for a second. The Affordable Care Act, right? That expanded the Medicaid programs. So is it that with these changes, there won't be, as you were saying, there won't be more people benefiting from the ACA, or is that not the correct way of looking at this?
No, the ACA massively expanded. So if you look at federal spending back in, as I said, if you look at federal spending on Medicaid back when the ACA passed, it's probably 200. I don't have the number on the chart, but it's roughly probably $220 billion. Now it's 600 billion, and even under the 650 billion, and even under this bill with the Republicans, it's going to be 850 billion in another 10 years. So you're basically slowing the rate of growth by making some what I think are modest, very modest changes. Are they going to affect some people? Yeah, but the idea that they're going to close rural hospitals, that it's going to take people, that babies aren't going to be paid for to be delivered, that's just made up stuff. I mean,
so Affordable Care Act, for most people know it as Obamacare. You're saying that situation will not cause that will. No. Obamacare will continue. It's not like suddenly people won't be able to get care. People will still be able to cover it under Medicaid.
A lot of people, like in New York, I think they expanded optional coverage in Medicaid up to like 600% of poverty. They put bigger. So President Biden, some I'm not going to agree or disagree with him. The ACA basically created exchanges, which are for people above Medicaid. They provide private insurance exchanges like the New York Exchange, and you can buy insurance through that exchange with a subsidy depending on your income. So you make too much money to be on Medicaid, but there's an income scale that goes up to 500 or 600% of poverty depending on the state that gives you a subsidy to buy private insurance through the exchange. Now those things were expanded significantly. They're created by the ACA, but there were 11 million people on that program in 2018. During COVID, because President Biden massively expanded the subsidies to make sure that people got insurance, it went up to 24 million people. Those fairly major expansions of subsidies for people expire gradually this year and next year. So that number is going to come back down to 16 million. So the issue there is, are you cutting, it went from 11 to 26 million, now back down to 16. Are you cutting the hell out of people and taking away subsidies from middle income people to get exchanges? Or are you taking away the enhanced temporary subsidies that were there during COVID and let it get back to where the ACA was? So you're basically going back to where the ACA was when Obama passed it. But I have to be a fan of exchanges. The issue for me is who gets subsidized how much. I'm a big fan of Medicaid. I think Medicaid's a wonderful program, but the people that are getting Medicaid should be, in theory, poor and needing it.
And also, I mean, one of the other areas that people get Medicaid, or two other areas, one that I wanted to mention was, right, those who have substance use disorders. I mean, 20% of the recipients of Medicaid have substance use disorders. So we don't want, and we know from what CDC has showed that number of overdose deaths have decreased in the last couple of years, which is probably because more coverage. So they won't, through these changes, they will still be able to get the coverage they need.
There is nothing in the bill specifying there's nothing that affects any specific coverage for hospitals, for doctors, or anything else. It's structurally, the provisions in the bill take people off the rolls who they think shouldn't be on the rolls, and you can debate that. In theory, somebody that doesn't meet their work requirement goes off the rolls. Somebody who's making more money than they should have and it wasn't determined before goes off the rolls. Somebody who's an illegal, who's undocumented alien. Obviously, that's a hot public debate. There's a number of states that cover that, will go off the rolls, but it has no impact on psychiatric benefits, on birth benefits. It's an overall tapping down on the number of people on there. And in theory, the big issue for which it's confusing as hell, I know, but the big issue for the states is starting to push back on provider taxes and these intergovernmental transfers and state-directed payments. These are, by any government, if I had the hours to explain it to your viewers, I don't. If I were running a state, I'd do the same thing. I don't blame them, but it's absolute financial madness that you have a program that's supposed to be a federal and state match, when in fact the states have creatively over the last 40 years found a way to not put up any money. I think New Hampshire puts up, I call New Hampshire "live for free or die," because New Hampshire
that's their motto. That's their motto.
They put live free or die. They live for free or die because they live in the other 49 states. They don't put any money in the Medicaid program, zero. It's all federally funded. So the other 49 states are paying for it. I'll give you one more example. I was Mitt Romney's health advisor and the chairman of his health group in 2012. Good guy, very reasonable guy, now retired. But when he was the governor of Massachusetts, you remember that they did the Massachusetts, wonderful, the premise for Obamacare, universal coverage in Massachusetts. Everybody gets coverage, all paid for, wonderful, fabulous thing. Well, how much money do you think the state of Massachusetts put into that universal coverage for Massachusetts? Zero, not one penny. It was all funded through a Medicaid scam, provider taxes, this financial, so it was billions and billions of dollars cooked up in Massachusetts to get universal coverage in Massachusetts, paid for by the other 49 states. So my argument is I'm happy to do all this stuff as long as there's rules and people debate it and understand it, and they don't. So you've got total scrambled eggs with 50 states and 6 territories having different rules. And the Medicaid is now the biggest program in the government. It combines probably, nobody knows, as I said, because the money's screwed up, probably $1.2 trillion a year spending. And the rules are undefinable and unidentifiable to any human being.
This is very helpful to clarify all of this. One of the other areas we spoke about the work issue. We spoke about this 12 million people losing their coverage, and you're saying that's not the case. But one of the other things is long-term care.
There'll be 12 million in 2034. Under the bill, there'll be 12 million fewer people on the Medicaid rolls than they would have if nothing had been done for the next 10 years. Do I think I think that's different than saying 12 million people are going to lose their coverage? If I were a Democrat, I don't blame it. If I were a hospital, if I were the head of the New York Hospital Association, I'd be screaming that too. That's just the way the politics works. But it's not really accurate.
So what about long-term care? Because a lot of people get Medicare, but then when others get Medicare and Medicaid, what happens to the individual who needs long-term care?
Long-term care is a third of the spending of the Medicaid program, and there's a problem there too. And then as almost everybody on this call probably realizes, there's an entire bar in the government built around, Medicaid's supposed to be for low-income people. The vast bulk of nursing home patients, people go on, you come out of a hospital. My mom and dad just passed away recently. You come out of the hospital, you go to a nursing home, and then after you're in the nursing home for 20 days and then 30 with the copayment, you're on Medicare for the first 20 days. If you stay forever and live in a nursing home, it's expensive. And so the vast bulk of people spend down their assets, transfer them to their kids, their biggest assets, usually their home, and they go on Medicaid. So Medicaid pays the bill. There are a couple of provisions in this bill that slightly tighten up on that, because in most states, what happens is people who are not, if you're poor, you should be have your nursing home paid for. There are a lot of people who are not poor that have houses that are $500,000, $1 million more, and they transfer them to their kids. And then the state of New York and the federal government pay, the vast bulk of the long-term nursing home beds in this country are paid for by Medicaid. And sometimes for people who are not poor. So there's a minor fix in this bill for that, but it's not going to affect many people. But generally, most nursing homes in the country are paid for by Medicaid. So your grandfather, your parent is in a Medicaid nursing home. They get Medicare for their physician services and things, but their day-to-day, the food, the housing, the basic cost of the nursing home is overwhelmingly covered by Medicaid. And it's a tough business. The Medicaid rates for nursing homes are not great, but most families don't want to pay. The actual cost of a nursing home bed is expensive, so people transfer the assets to their families, And there's state by state, those rules vary. And then they get their mom or their dad in a nursing home, and the state of New York or whatever state they're in pays for. So that's a healthy debate as well. I mean, I would have said, and I spent years when I was in the government 25 years ago trying to say, look, if you're a certain level, you can't do that. You got to put your assets in it. Your mom and dad have a house that's worth $200,000 or $500,000. You got to put that in a trust and spend down the value of that before the state of New York starts paying for your nursing home. That's a very, very controversial. That's not in this bill, by the way, but that's a very controversial. I would have done that because I think Medicaid should be for people who are truly low income. And if you have a $500,000 house, you should use that to pay for your nursing home before the state of New York does. But that's not the way the law works.
It's a very controversial issue. I remember this from when I was in New York as the commissioner. One of the other things I do remember is we were spending about $90 billion on Medicaid in New York. Maybe it's $100 billion now. A lot of money that goes out for that. But I do know that if this was happening right, or I bet again, if I was the commissioner right now, the governor or state Medicaid director would be probably calling, if you were the CMS director, calling you. So would they be banging down your door in protest or praise? What would you be hearing if you were sitting there right now as the CMS director? Medicaid
people would scream at you about, usually what they're asking for is they're asking for waivers, and they want more. They want more money to do more stuff with their program. So in the middle of this, they're saying, I just passed a provider tax for X, Y, and Z. It's going to cover all these people in Pennsylvania. And if you make sure you don't put this in the bill to screw up my program for the next 10 years. But they're asking, look, they're always asking for more money, period. So, I mean, I give you a million examples. In 1990, one of the first states to really cheat on these provider tax donations was Tennessee. It was out of control and it was terrible. And I basically shut them down, said I wasn't paying for the matches. And we had about a massive fight for a year. I happen to know the governor pretty well and his finance guy. And I compromised eventually. They want to do all these expansions. I said, look, we're not going to give you this free money. It's crazy. These provider taxes you're doing are bogus. But I'll give you basically, you mentioned the block grant in your note last night. There are no block grants, but there are some states that get a waiver. I basically said, here's the deal. I'll give you X number of dollars per person. Still be an entitlement. You can provide all these extra benefits and expand the program, but it's got to be under a capitated defined budget so we can control it. And if you want to do the expansions, we'll match it, but we need to have it in the defined program. So they created TennCare, which is still going on, through a waiver. And we basically worked it out where we could at least manage it and make sure they didn't, cheat on everything. I can give you a million examples of how this program's going. I'll give you 2 or 3 fun facts that you won't believe. So this is just to tell you how long it's going on. In 1992, George Bush, who I loved, was running for election against Bill Clinton, who we also learned to love later. Bush and Clinton got to be good friends. We were probably going to lose. The state of Maryland was peppering me. William Donald Schaefer, Democratic governor, would call me up, and his chief of staff would call me 3 times a week. You got to give us this provider tax waiver it was like $275 million. And they wanted it so badly, and they screamed and yelled at me for a year. And I said, no, it's bogus. I'm not doing it. And about a week before the election, James Baker, who was then the White House chief of staff, incredible guy, calls up and said, Scully, what's going on with this provider tax? I said, Mr. Secretary, he'd been the Secretary of State before he came over. It's terrible. It's bogus. I've been fighting it for years. It's complete garbage. Don't give it to him. He said, all right, I got it. 4 days later, just before the election, he called me back and said, Scully, give Maryland the money. I said, don't make me do that. They said, you know what? I don't want to argue with it. Don't. Just give them the money. And you can go back and look in the paper. 4 days before the 1982 election, William Donald Schaefer, the Democratic governor of Maryland, endorsed George Bush. We were going to lose anyway, but think about that. That's how heated these things got. I gave him the $275 million, and he endorsed George Bush, a Democratic governor who's now passed away. I wouldn't tell you that story. When Bush lost, and he went to one meeting between Bush and Clinton on January 20th, I was still in the White House in 1992. And they got to be great friends later, but they weren't at the time, because you can imagine. They had one big discussion. Jim Floyer, the governor of New Jersey, wanted a $400 billion scam that he wanted to use to get money from New Jersey. And John Engler of Michigan had $500 million. And Engler had been calling Bush, give me the $500 million, and I've been sitting on it. Floyer had been calling me saying, I want the $400 million, and I've been sitting on it. And they went to a meeting for like 2 hours in between the administrations. And only Bush and Clinton, and a couple of people, Andy Card, who was the deputy chief of staff. And they came out of the meeting because I pleaded with Bush, and don't give away the money. It's bogus. Don't do it. And of course, they came out of the meeting. What do you think happened? They agreed to give both of them the money. So Last day of the administration, Bush gives Lingo $500 million, totally bogus, and Florio gets $400 million because Clinton asked for it, and they happily gave their buddies free money that was completely insane and happily went on. This has been going on. This is 1992. So my point is, this is not a new problem. It's been going on for a long time.
Politics is politics. You're going back 30 years now, 32 years. And so
it's bad financial management. If you're taxpayer dollars, and I love I love George Bush. I actually really learned to like Bill Clinton. But, they didn't really understand what the hell they were doing either. But these are very big public programs, and the pressure is enormous. And if I was the governor, I'd scream and yes to get calls. These are the calls you get. I'd say I want more money. I want more money too, because why not get federal money if you can't get state money? But, a lot of these states have big surpluses. As I said, in New Hampshire, they put a penny in for decades. And it's just, there ought to be some rules where all the states help their poor people by the same set of rules, and that does not exist. And that's the sad thing about all this.
But with all the politics out there, this is why the average person, the average American, sort of says they don't trust anyone. This is what happens, because everyone starts to wonder, what's really happening? How will it affect my life? That's what they wonder about.
There's not much in this bill that's going to affect individual lives, unless they're still undefined. If you're not a documented alien, if you're an undocumented alien, or you happen to have work requirements, or you're tiptoeing around the income verification rules of when you should be on Medicaid, it's probably going to affect your life. It's not going to directly affect any hospital. It's not going to directly affect any provision of any care, because it's all done state by state. It may affect the flow of funds a little bit, because the states won't have quite as easy a time coming up with these new grandfathered and everything's there now. But the projection of the budget was all these guys are going to have all these new provider taxes and new intergovernmental transfers and new state-directed payments, all these ways to get free money from the federal government. And the federal government basically said, we're going to freeze what we have today, but no more. So basically freezing the program where it is today. So the states are saying, oh, this is terrible. We're not going to cheat as much going forward to get extra money. That's basically what they're saying. And you're going to make our lives tougher. So if you do that, we're going to have to shut down some rural hospitals. That's not why they're going to shut down rural hospitals.
I think I'm going to ask you about 3 takeaways. Probably one of them, which you already gave me, is that this won't affect things. But I'd be foolish if I didn't ask one big question. I know it's a complicated one, but any major changes on the Medicare side? Because I'm sure everyone's wondering whether Medicare is going to be affected, and so many million Americans are affected by it.
Zero, not a word in the bill of Medicare, which is shameful.
That is so important. Well, that is so important to know that Medicare will stay the way it is, and people worry.
There's a lot of things that Medicare could, look, you read the Wall Street Journal. I'm not trying to pick on United, but obviously, United has been aggressive on coding on risk adjustment, and there's been questions about Medicare Advantage, which, as you know, I made up that name, and I arguably, along with some other people, created that program back in 2004, 2003. So I love Medicare Advantage, but there's a lot of things that could and should have been done in Medicare Advantage, but because they're so worried about touching Medicare because of midterm elections next year, they didn't touch Medicare, which I think is when you have a $2.5 trillion budget deficit and you're paying $1.1 trillion a year in interest on the debt. It's insane to do it. I'm upset about the rhetoric about the Medicaid cuts, because look, they're changing Medicaid very marginally. Do I think it's going to hurt anybody? No. I think the hysteria is really off the wall. But I'm embarrassed to be Republican. The fact that somebody went out and basically expanded these massive tax policies without doing any offsets to pay for it, and the deficit is going to go up $3.5 trillion is nuts. So they're both acting atrociously.
It is amazing when you think about it. It's just more zeros. It's unbelievable. These numbers are enormous. 3 takeaways.
We just have to hope that the Japanese, the Chinese, the Russians, these guys all buy our bonds. And there's bond auctions every week. And if all of a sudden they start saying, guess what? Because we're the safest place in the world to put your money. All these foreign countries said, you know what? We're not buying your bonds anymore. Interest rates will go through the roof, and we're going to have a total crisis. I hope it doesn't happen, but it's certainly not unlikely.
Another whole incredible issue worth sitting down for an hour and talking about, as well as Medicare. 3 takeaways on Medicaid that you think that everyone should know. One, I think you're saying that this is not going to affect anything, but what would be the 3 that you want?
The states will be pressured a little bit, lightly, and way less than I would pressure them if I were a benevolent dictator. But you got to deal with politics to basically rein in their programs and make sure that they manage. They're not going to get free money the way they had been. they're going to get everything they're doing today grandfathered in. So basically, over the next 10 years, they're not going to, every time they want to do something, just go charge 95% to the federal government. How accountable are you going to be if you're running a program in New York and the federal government's paying 95%, or in New Hampshire's case, 100%? What the hell? It's Christmas. Just do whatever you want. So there is going to be a little bit of pressure. And as I told you on the numbers, Medicaid spending is going to go from $650 billion, this year. Without any changes, it's going to go to $950 billion in 10 years, and it's going to go to $850 instead. So it's still going up specifically. I mean, it's going up dramatically, but nowhere near as dramatically as it would. So is there going to be some pressure if you're a state Medicaid administrator to be, to prioritize and make tough calls? Yeah. Is that going to cut people? I mean, for me to go from $650 to $850 billion in 10 years in spending is not a cut. It's a tightening of the belt that maybe caused some pressures that otherwise weren't there. But I don't think it's going to be dramatic. And you're, concerned about rural hospitals. And look, 50% of the live births in the U.S. now are paid for by Medicaid. Is that going to be affected? No. Is a rural hospital going to still have problems because the town's half the size it was, and they got a large hospital that's got large costs that they can't fill with, can't get doctors to come work there? That's a structural problem that we all have to deal with. I don't think it has anything to do with this bill.
All right, perfect. I wrote those down. We're going to capture them and make sure our audience hears it. This is when we reach the point in the show when I have the audience ask questions. So I always mention here that the podcast is just for informational purposes. Any medical questions you really should ask your doctor about. But let's turn to our audience and see what questions they may have. Kat, who do we have up there? You usually have the first question.
I do, and we have a few questions since we're running tight on time. I have a question, and then I'm going to bring up Anna. I'm going to ask a question from one of the subscribers. Mr. Scully, is there a way for the government to assess the effectiveness of the changes in the work requirements and the changes to the program? Whatever information you might have on how that process will go.
It's state by state. Arkansas did it. I would say it was mixed bag, probably didn't work very well. The argument was that a lot of people get the process and the questioning of whether you did enough work or not that was a hassle, and that some people got thrown off the rolls because of paperwork. It's a state by state thing. So my hope is, I'm not a huge fan of work requirements. I think it's worth trying. Do I think that's going to dramatically change the program? I think we need to watch it, and I hope they're going to monitor it. And if it turns out it's not working well, the states will back off on it. But I think it's a mixed bag. Kentucky, Arkansas, a couple of states have tried it, and I would say it's a mixed bag, and I expect a mixed bag. I'm not a huge fan of work requirements. I can understand why you want to do it. I think it's worth trying. I think they should be very careful that if it screws up the program and people are losing services, they should drop it. So I'm not jumping them down work requirements, but they're in there, and I don't think it's going to destroy the program. So, in my opinion. If most of the stuff you hear is about women and children losing Medicaid, to be even exposed to work requirements, you have to not be one with child. You have to be a single person who's covered in Medicaid by income level. So, the truly most sensitive people in the program aren't affected by it.
Okay, perfect. I hope that answers our subscriber's question. I'm going to bring up one more subscriber. Anna has a question.
Hi, Dr. Zucker. Hi, Mr. Scully. Thank you for the timely podcast this morning. You mentioned Medicare won't be impacted. So there aren't any implications in the legislation that will impact people who are dual eligible beneficiaries?
Well, it'll be dual eligible beneficiaries potential, because by definition, dual eligibles is Medicare and Medicaid. But the Medicare side, that's not affected at all. There's no language. Believe me, I think it's a mistake, but I can tell you by talking to the people that, even last winter, because what I expected, in my humble opinion, in a normal budget process, the way the government should work, that doesn't anymore, is you have a big tax cut. Once they extend, you pay for it. And the way you pay for it, which got George Bush fired in 1982, is you either raise taxes or you cut spending to make sure that you're not increasing the deficit. They basically waived all that. So, but President Trump, from the very beginning, when I started talking to staff in the White House about policy, I assumed they'd have to do all kinds of stuff to pay for this. And they said very clearly last January, President Trump has said, we are not touching Medicare, nothing on Medicare. So there's not a word in the bill about Medicare. every state has dual eligibles, and every state's different because it's a combination of your dual eligible covered by Medicare and Medicaid, and it's different in every state because the state Medicaid programs differ. So if a state changes its Medicaid program, it could affect dual eligible state by state, but nothing in Medicare.
Okay, thank you.
Perfect. That is very helpful. I know we're tight on time, so I want to thank you. This has been a great discussion. You've explained what the bill has and what really is going to happen. I think this has clarified a lot of the confusion that people have out there. So I'm glad you did this. You're always so candid. You're so candid about things, and which is great. Which is great. Brings me back 25 years to the conversations we used to have. I would love to continue.
Back then, when things are getting really old, is when you're really old, you can say whatever you want.
It's like, no, I remember when you're very candid about some of the things that came up. That's why I said, like, I remember Thompson saying, well, we'll fire Scully, then we'll rehire Scully. And he worked a lot on these issues as well in Wisconsin before, right? Because there was Badger Care, right? Wasn't Badger Care part of the whole issue of how to provide health care? And we're going to have him on in a couple of weeks as well. So that'll be great.
Good. Well, I love the time I said hi. I remember when you walked in as our resident intern right from the beginning, and you were uniquely nice and pleasant and fun. So it was always...
Thank you. As a White House fellow, boy, I was young. I was like, didn't know the whole system, didn't even know how government worked. Now I sort of understand, exactly all the complexities there. But I'd love to.
I never knew your politics. Until you worked for Governor Cuomo, obviously, which had some. But I hope you would say, from your experience with Tom Thompson, to me that I think most people, Democrats and Republicans, are trying to do the right thing. And all this, what drives me crazy is the back and forth about people doing evil, terrible stuff. Most people, the left is going further left, the right is going way further right, unfortunately. But most people are trying to do the right thing.
I mean, that's how I've always felt. And I remember when we had these conversations with Thompson, it's like, well, how does it affect a person? I remember sitting around that big wood table. It's like how does this actually affect people? And all the other stuff was sort of need to be worked into that whole issue. But I feel it's become so much more partisan now because we had 9/11, we had the closure of the Capitol during anthrax, and I remember sitting up there with both sides of the aisle. Frist was on one side, Daschle, not on other sides of the issue, but on different Republican versus a Democrat with Daschle and Frist and Daschle there. And we sort of said, okay, how do we get this Capitol back open? How do we get government moving? And sitting there, the discussions were in this battle and fighting back and forth. It was really a much more of a collegial spirit. Things have changed.
I mean, Tom Daschle
fought, but it was
my law partner for 15 years and for a number of years, and Bill Frist is still a close friend. They're both great guys. I mean, they were doing, like I said, about the governors are going to ask for money because that's what their job is. Tom Daschle fought like crazy to not let us pass some of the stuff we did because he thought it was bad for the Democratic Party. But he's a great guy, and Bill Frist is a great guy. I remember in the first Bush White House, George Mitchell was the Senate Majority Leader. I dealt with him all the time. He had more to do probably with George Bush not winning any election and losing to Clinton than anybody because he just beat the Ellis every day. But he was a nice guy. He was a gentleman, and he did it in a decent way. So, look, politics is politics. My view is you should be able to disagree rapidly and still go off and have a beer with somebody at the end of the day, and that's not happening much anymore.
Well, hopefully things, the temperature drops a little bit on all of this arguing, is because we're all in it to try to help the country move forward, and maybe have different opinions, but the goal is to help Americans. Thank you so much. We should sit down.
Howard Zucker for president. Was it 2028?
Okay. Thanks a lot. I'll get a bumper sticker. We should have dinner at some point. I would love to sit down and have a conversation with you about not all this stuff, but just reminisce and also talk about many other things that are healthcare policy issues that are out there. That is it for our show today. Remember, if you are a Docology subscriber, you can join the conversation. You just have to sign up for the email reminders about the upcoming episodes. You could do that at docology.life or Substack. You can listen to our podcast on Apple or Spotify. But tune in next time because the topic we cover may just save your life.
Thanks.
Docology is a production of Hang Media. Our producer is Catherine Warren. Ronnie Selig is editorial advisor. Our creative director is Anna Richard. Janine Wilson of Wilson Media Group handles paid marketing. Our publicists are Leslie Ann Wade and Jerry Caracoli. Theme music was composed by Nick Kitts. Subscribe and join our community at docology.life. Until next time, move, wash your hands, and stay healthy.